So for our final section of this chapter, we'll talk about cardiac output. Cardiac output will consider the heart rate and various things that control the heart rate, as well as the stroke volume and the things that control stroke volume. So there are two variables that go into cardiac output, both heart rate and stroke volume. When we multiply these two variables, we'll see that at rest we have about 4 to 6 liters per minute circulating through our body. That means that a red blood cell leaving the left ventricle will take about 1 minute to return to that left ventricle. That's pretty impressive. Vigorous exercise can increase the cardiac output to about 21 liters per minute in a very fit individual, and 35 liters per minute for a world-class athlete like, say, Lance Armstrong. A cardiac reserve is the difference between a person's maximum and resting cardiac output. Naturally, this increases with fitness and decreases with disease. So people with severe heart disease may have little or no cardiac reserve and thus little tolerance for physical exertion. So given that cardiac output is a combination of heart rate times stroke volume, there's only two ways to change the amount of blood circulating through the body. So as we age, the stroke volume is going to decrease. To compensate for that and keep the same amount of blood circulating, we're going to increase heart rate slightly. So we can measure heart rate easily by taking a person's pulse at some point where an artery runs close to the body surface, such as the radial artery in the wrist or the carotid artery or maybe even the brachial artery in the arm. This pulse is produced by a surge of pressure that's produced by each heartbeat. Infants have a heart rate of about 120 beats per minute or even more. Young adult females average 72 to 80 beats per minute, and young adult males average 64 to 72 beats per minute. Again, the heart rate rises in the elderly. When heart rate is above 100 beats per minute, it's considered tachycardic. This can happen because of stress, anxiety, drugs, heart disease, fever, especially during loss of blood or damage to the myocardium. Bradycardia is the result of a low heart rate, so less than 60 beats per minute. It happens during sleep and during very low body temperatures. And we see it also in endurance-trained athletes. So we've already established that the heart is autorhythmic. That is, the autonomic nervous system doesn't initiate the heartbeat. However, it does modulate the rhythm and force of that heart rate. We've already looked briefly at the sympathetic and parasympathetic innervations. Now we're going to take a closer look. Without the influence of any cardiac centers, the heart has an intrinsic natural firing rate of about 100 beats per minute. And as you know, 60 to 70 is more normal for us at rest. And thus the heart is under parasympathetic control through the vagus nerve to suppress heart rate. The cardiac centers in the reticular formation of the medulla oblongata will initiate this autonomic output to the heart. We have both cardiostimulatory effects in sympathetic pathways, like in the event of heavy exercise, we need to raise the heart rate above 100. And we have cardioinhibitory effects through the parasympathetic vagus nerve route. We'll look briefly at each sympathetic and parasympathetic effects. The sympathetic, again, is fight or flight. So postganglionic fibers are adrenergic, that is, they release norepinephrine, you'll recall from last semester. This norepinephrine binds to beta-adrenergic fibers in the heart, which activates the cyclic AMP second messenger system in both the cardiocytes and the nodal cells. This leads to opening of calcium channels in the plasma membrane and an increase in flow of calcium, which causes accelerated depolarization of the SA node. So we reach that pacemaker potential much more quickly. Cyclic AMP accelerates the uptake of calcium by the sarcoplasmic reticulum, allowing the cardiocytes to relax much more quickly. This can increase the heart rate to as high as 230 beats per minute. Now, it's topped out at 230 because of the refractory period. If diastole becomes too brief to allow for adequate filling, then we'll see that the stroke volume and cardiac output are reduced. So 230 is about the max. And that declines with age. The parasympathetic inputs have cholinergic or inhibitory effects on the SA as well as the AV nodes. Cholinergic means it's activated through acetylcholine, and that binds to muscarinic receptors. Once acetylcholine binds to the muscarinic receptors in the AV and SA nodes, it's going to open potassium gates in those nodal cells. Potassium will leave the cells, and thus they become hyperpolarized. And thus it takes longer for the pacemaker potential to reach its maximum. And so the heart slows down. The parasympathetic works on the heart much faster than the sympathetic input because the parasympathetics don't need a second messenger system. The idea of vagal tone is that we're holding the heart rate down at around 70 to 80 beats per minute. There's constant parasympathetic input on a resting heart to keep the steady background firing rate. And it comes through the vagus nerve, and that's why it's called vagal tone. So what are the inputs to the cardiac center that will influence this parasympathetic or sympathetic control? There are many sources that need to be integrated from higher brain centers. The cerebral cortex will have its inputs, the limbic system will have its inputs, and the hypothalamus will certainly have inputs. So the fact that the limbic system's involved probably reminds you of emotional stimuli. And you know that emotional stimuli will affect our heart rate, and certainly sensory stimuli. We'll look at some of the sensory mechanisms coming up here. The medulla is also going to receive input from muscles and joints and arteries and the brainstem. There are proprioceptors in the muscles and joints. They inform the cardiac center about movement in the periphery of the body. If there's movement in the periphery of the body, then perhaps increase in heart rate is going to be useful to take care of the metabolic demands of the muscles as they arise. In addition to that, we'll see baroreceptors or pressure receptors. They also signal the cardiac center. When the pressure sensors in the aorta or the internal carotid arteries detect a drop in blood pressure, then they will have less signal to the cardiac center, and thus the heart rate will increase because there's less parasympathetic input. If the blood pressure, however, increases, the signal rate of the baroreceptors or pressure receptors rises, which stimulates the cardiac center to have greater parasympathetic input and decrease the heart rate, and thus drop the blood pressure. We'll also see a family of chemoreceptors, some in the aortic arch, some in the carotid arteries, and some in the medulla oblongata. They're sensitive to pH, CO2, as well as O2 levels. They're much more important in respiratory control than cardiac control, so we'll visit with them a lot more in a future chapter. But if CO2 accumulates in the blood and cerebral spinal fluid, then it will react with water. It causes the release of hydrogen ions, and thus we see that the pH becomes lower. Remember, increased hydrogen ions, lower pH, more acidity. And this creates a case of acidosis, which will certainly influence the cardiac center to get rid of more CO2. Hypercapnia is the name that we give for the condition of having too much CO2. We also will respond to hypoxemia, low oxygen in the blood. Usually this will have kind of an odd effect to slow down the heart. And what that does is preserve oxygen for the brain. Now, we're going to learn that these O2 chemoreceptors have a much more delayed effect than the CO2 receptors. There are also many chemicals that affect heart rate, as well as the neurotransmitters from cardiac nerves. As you may recall from last semester, when the adrenergic nerves release their neurotransmitters, for example, norepinephrine and epinephrine, there's also a release of the same chemicals from the adrenal glands as hormones into the blood. And so the heart is not only having influence from the neurotransmitters, but also these chemicals that are floating around in the blood. You're well aware of this effect. When you first experience a fight or flight, your heart rate increases instantly. Even once the stimulus for the fight or flight is removed, we still experience a racing heart. That's because of the norepinephrine and epinephrine that we find in the blood that's still circulating around and having a profound impact on the heart rate. There are several drugs that stimulate the heart. Nicotine, for certain, stimulates catecholamine secretion. We'll see thyroid hormone increases the number of adrenergic receptors on the heart. So thyroid hormone makes the heart more responsive to sympathetic stimulation. Caffeine will inhibit cyclic AMP breakdown, which means the cyclic AMP stays around for longer and prolongs the adrenergic effect. We'll also see electrolytes have a big influence. Potassium has the greatest influence. Hyperkalemia is when we have excess potassium flowing into the cardiocytes. It inhibits the repolarization. So the myocardium is less excitable and the heart rate slows and becomes irregular. So it's important that we don't have too much potassium in the diet. Hypokalemia, or low calcium in the blood, we'll find that potassium diffuses out of the cardiocytes. The cells become hyperpolarized, and thus they require increased stimulation. So the right potassium level is very important. Calcium also has its effects. Hypercalcemia, having too much calcium in the blood, decreases the heart rate and contraction strength, whereas hypocalcemia will increase the heart rate and contraction strength. These calcium imbalances are relatively rare, but when they do occur, their primary effect is on contraction strength. We'll look at this more in a future chapter when we explore the effects of imbalances of potassium, calcium, and other electrolytes. So now we've considered all the things that might affect the heart rate. Let's look at some things that affect stroke volume. There are three variables that we can consider in stroke volume. There's preload, contractility, and afterload. Preload is the amount of tension in the ventricular myocardium immediately before it begins to contract. Contractility is how hard the myocardium contracts for a given preload. And afterload is the blood pressure in the aorta and pulmonary trunk, immediately distal to the semilunar valves. So let's look at preload. Preload, again, is the amount of tension in the ventricular myocardium immediately before it begins to contract. This increased preload actually causes increased force of contraction. So basically, the more the muscle is stretched, the more force the contraction will have. Exercise increases the venous return, thus puts more blood into the atria and stretches the myocardium. This generates more tension in the cardiocytes during contraction. And this increased cardiac output is going to match the increased venous return. There's an important guy in here, Frank-Starling. He has the law of the heart, which says that stroke volume is proportional to the end diastolic volume. You'll recall that the end diastolic volume is how much blood is left in the heart at the end of filling. The ventricles are going to eject as much blood as they receive. So his idea is exactly that the more the ventricles are stretched, the harder they'll contract in order to remove as much blood as arrived there. Contractility refers to how hard the myocardium contracts for a given period. There are going to be things that are positive ionotropic agents that increase the contractility. We've looked at a couple. Hypercalcemia can cause strong and prolonged contractions, sometimes even to the extent of cardiac arrest and systole. Catecholamines will increase calcium levels. Glucagon will stimulate cyclic AMP production. And digitalis will raise the intercellular calcium levels and contraction strength. Negative ionotropic agents that we've already looked at would be hypocalcemia, causing weak and irregular heartbeat and cardiac arrest and diastole. Hyperkalemia, which reduces the strength of the myocardial action potentials and thus the release of calcium into the sarcoplasm. And then the vagus nerve will have an effect on the atria, but too few nerves to the ventricles to have any significant effect. Afterload is the blood pressure in the aorta and pulmonary trunk immediately distal to the semilunar valves. This afterload opposes the opening of the valves and thus limits stroke volume. In the case of hypertension, we'll see an increased afterload, which opposes the ventricular ejection. So if there's less distensibility in the aorta or pulmonary trunk because of building of scar tissue, then we'll see increasing afterload. Basically, anything that impedes arterial circulation will increase the afterload. Lung disease can restrict the pulmonary circulation because of scarring. It's a condition called cor pulmonale, which is where we see the right ventricle fail due to obstructed pulmonary circulation. Sometimes this happens as a result of emphysema or chronic bronchitis and black lung disease. So exercise obviously has an impact on cardiac output also. It makes the heart work harder and thus increases the cardiac output. We'll have increased venous return and increased contraction strength. Proprioceptors in the extremities will signal the cardiac center at the beginning of exercise, and signals from these joints and muscles will reach the cardiac center of the brain, which increases sympathetic output and thus increases the cardiac output. The increased muscular activity will increase venous return, and that increases the preload and ultimately the cardiac output. Exercise will produce ventricular hypertrophy in a good way. It increases the stroke volume and allows the heart to beat more slowly at rest. Athletes with increased cardiac reserve can tolerate more exertion than a sedentary person because of this training on the heart. Basically, we make the heart work hard and it increases its muscular contraction strength just like any other muscle. This concludes our chapter on the heart. Take some time here to consider the different aspects of cardiac output. What things might affect heart rate and what things might affect stroke volume. And ultimately, those will tell you the things that could influence cardiac output. Don't forget to explore the interactive artwork as well as other resources in Connect. Do your Learn Smart module, and now there's definitely material to explore in Anatomy and Physiology Revealed. It's a lot of material to put together, but all the diagramming will help you synthesize it all.